It's a real pleasure to present to you all on work that my colleagues and I have been doing on how to address opioid use disorder and chronic pain. I have no financial disclosures. This is the motley crew who started this pain clinic back in 2008. We're primarily a training clinic of sorts, and some of these folks here, and I take credit for everything, right, that goes well with these people. This was an intern, Lana, who's now a clinical psychologist. Mark and Chris are still with me. They're clinical and counseling psychologists. And Sandy in the middle is now a lecturer. She was a pre-doc psychology fellow. She's now faculty at Yale. And the guy on the right-hand side was probably the smartest of all of us. He was a research assistant who's now a surgeon, a back surgeon, and doing well in the Cleveland Clinic. So as I said, we take credit for everything that goes well with these people. The aims of today's talk, I'm going to go over with you just work that we've been doing and other groups have been doing on who are these patients who've got chronic pain and opioid use disorder. Okay, sure. Thank you for that. Right? And the challenges that providers have who deal with these patients. Then I'm going to go over with you an integrated treatment approach that we've been developing, and then how we've been trying to dismantle this approach so that it can be provided in different settings. Okay. We could spend a lot of time just talking about this part of a Venn diagram about how many people in this country have chronic pain. And chronic pain is usually defined as pain lasting 3 months or more, because you would expect after 3 months that most of the healing that's going to have occurred has already occurred, right? It wasn't that long ago that the Institute of Medicine back in 2011 estimated that 100 million Americans had chronic pain. The CDC now estimates it's 25 million. Where that 75 million went is up to anybody's guess, but it probably shows you in part, the previous speaker was talking about, how this epidemic got started. Back in 2008 when I started doing research in this area, and I would go to pain conferences, people would tell me, the real crisis is untreated pain, right? And this is a line that I'm based in Connecticut, and Purdue Pharma is also based in Stamford, Connecticut. This epidemic in some parts can be viewed through the lens of 2 medications that Purdue Pharma released. Back in the mid-'80s, they released a blockbuster medication called MS-Contin. And back in the 80s, there was an international consensus that people who had chronic pain should not be exposed to opioids because there was a risk of addiction, right? And that opioids should be reserved for people who've got cancer pain and who have end-of-life pain going on, or for people who have been involved in injuries in the emergency department, but there should be a lot of caution that people could become addicted. And on the insert of MS-Contin, it said not to be used for people with non-cancer chronic pain. In the space of 10 years, when it released OxyContin, the whole environment in this country had shifted, not elsewhere, but in this country, right? So when OxyContin was released, Purdue Pharma now had FDA approval to prescribe OxyContin for people with non-cancer chronic pain, right? And then in some ways the rest then is history, right? Because they convinced the FDA, in part based on the letter that the previous presenter showed, right, where the risk of addiction was estimated to be less than 1%. And then there was also a second study That was a case study of 38 patients that cancer researchers in New York looked at, and among these 38 patients who didn't have cancer pain, they estimated that the risk of addiction was less than 1%, right? And based on these case studies and on the letter, opioids became freely available in this country, not as an adjunctive form of treatment, but as a mainline treatment for chronic pain. The CDC guidelines that have come out 2 years ago or so has now swung back the pendulum, where people who've got chronic pain, according to the latest CDC guidelines, should not be prescribed opioids routinely, right? That it's no longer the mainstay treatment. But in the mix, many people have developed an opioid use disorder. So if we were back in the year 2000, the federal government estimated that 0.6 of 1 million had an opioid use disorder. Now the latest figures are between 2.1 and 2.4 million individuals in the United States have an opiate addiction. And this is thought to be an underestimate because it's based on surveys that involve phoning people in their houses, right? That this estimates come up. But the number a lot of people think is actually significantly higher. Now there are some people who've got both of these chronic relapsing conditions, right? And both of these conditions are viewed as chronic and relapsing, so that you would expect people to be stable for periods of time and then to become symptomatic and relapse, right? And that happens both with pain, so that you might have people whose pain has been adequately managed, but then will have a pain flare-up. Or you might have people who've got opioid use disorder who are stable for periods of time and then out of the blue become symptomatic, who develop lots of cravings and who maybe periodically relapse or use, right? And that we shouldn't be shocked if people who've got an opioid use disorder relapse, even when they're on treatment for opioid use disorder. Like the previous speaker mentioned, the evidence-based treatments for opioid use disorder are primarily medication-based, right? So you've got methadone treatment, you've got buprenorphine treatment, and you've got naltrexone treatment. And these are the 3 FDA-approved medications for opioid use disorder that are evidence-based. What do these medications do? They essentially reduce down withdrawal symptoms. So if you were to look at a patient who is coming on to treatment, the classic example would be somebody who's taking heroin, for example. And if you were to follow somebody in the throes of heroin addiction prior to coming in for treatment on one of these medications, probably what you would see is fluctuation between the person going through withdrawal, right, which is like a very, very bad flu, having these strong urges to use, that opioids and heroin occupy a lot of their time. Then they use, maybe get a high or euphoria. Then after 4 hours or so, they crash and they go through withdrawal. And much of their life is spent between getting some kind of high or euphoria and withdrawal. And very little time is spent feeling normal, right? The purpose of these 3 medications, methadone, buprenorphine, and naltrexone, is simply to disrupt that cycle, right? So the people who are on these medications, what happens? They no longer are experiencing withdrawal symptoms, their cravings are going down, and if they were to use heroin, for example, while on these medications, they're no longer getting this euphoria, right? So that's essentially the purpose of these medications. And one of the ways you can see they're working is that people often report that they feel normal, right? So part of the purpose of these medications is that they get a person back to feeling normal so that they can then pursue other areas of their lives like work, right? Family, friends, meaning, right? So it so happens then that there are some people who've got both of these chronic relapsing conditions, right? So who've got chronic pain and who are addicted to opioids. While there's currently evidence-based treatments for chronic pain, and separately for opioid use disorder, there's a paucity of evidence-based approaches for people who have both, right? And one place to start thinking about how we could come up with an evidence-based approach for people who've got both is to look at people who've got opioid use disorder who are coming on to methadone, buprenorphine, or naltrexone, and who happen to have chronic pain. Right? Okay, so what is pain? So pain, according to the International Association for the Study of Pain, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. One part that's often overlooked here is the emotional experience, that if you look at the pathways or what gets lit up in the brain, that similar pathways get lit up whether it's emotional pain or physical pain, right? And that you might find that as you're working with patients who've got physical pain, that emotional pain is often intimately tied up with their experience of physical pain. Okay, so Dr. Levanus was talking about this, biopsychosocial model that is probably the best guess of how to go about treating opioid use disorder. The same thing applies to pain, right? So that if you look at from the mid-'80s to now, the primary type of chronic pain that people have in this country is low back pain, right? So if you haven't experienced low back pain yet, you will, right? And then there are some people who, when they have low back pain, the pain goes away after a period of time, but for others the pain lingers, right? And it becomes chronic. The primary evidence-based treatment for chronic low back pain is interdisciplinary pain management. What does that involve? It involves getting the person active. Probably the primary mistake that people make who have low back pain is that they start becoming sedentary. One of the things you want to do with patients who've got low back pain is get them moving. The American College of Physicians came out with recommendations a couple of years ago about low back pain. What was their primary recommendation? Get people moving, right? So that the mistake a lot of patients make is something like, well, if I'm in pain, I shouldn't be moving. But then by not moving, they're actually becoming more deconditioned. They're probably putting on weight, and they're more prone to experiencing pain, right? So one part then of this biological part of pain management is getting people moving. Medication is also a part of interdisciplinary chronic pain management. The typical medications that used to be used and that now are coming back more into vogue are antidepressants, right? That low-dose antidepressants from SNRIs to SSRIs are quite effective in managing chronic pain, and so are things like non-steroidal anti-inflammatory drugs. NSAIDs are also quite effective. And what's interesting is that what's not effective for low back pain are opioids. Yet, over the years, if you look at the composition of pain clinics in this country, the number of pain clinics that offer opioids and surgery as the main intervention has increased steadily. The number of clinics that offer interdisciplinary chronic pain management has decreased steadily. And that probably goes back to reimbursement strategies, right? That what gets reimbursed until quite recently has been not, Dr. Levanus was talking about, motivation interviewing, CBT. These are all strategies that are useful for chronic pain and opioid use disorder, by and large, are not well reimbursed. What is well reimbursed? Opioid medications tend to be well reimbursed, and so do surgeries, right? And most back clinics are not charities, so follow the money, right? And you see what gets offered. One thing that probably often gets overlooked is sleep, right? And that one of the problems that many of our patients face who've got chronic pain is that it interferes with their sleep, right? And one of the challenges of working with patients who've got chronic pain is that they often view everything through the lens of pain, right? And that part of what providers get pulled into is something like, you need to get rid of my pain, you get rid of my pain, then I'll do what you want me to do, right? So part of your challenge then, if you work with these patients, is not to fall into that trap, right? And it's probably a trap that many physicians and prescribers fell into, that if you want to get rid of somebody's pain in the short term, there's probably nothing more effective than opioids, right? They're excellent at removing pain in the short term. But when it comes to chronic pain, increasingly it's becoming obvious that this is not an effective strategy for most people who've got chronic pain, right? And that there are lots of risks associated with using opioids for chronic pain. One of them being addiction, another being opioid overdose, that as people move from 50 morphine equivalent daily doses of opioids, their risk of overdose increases substantially. And then when you move from 50 to 100, it goes up again. What's interesting is that lots of physicians and prescribers were trained in a notion that, well, you prescribe opioids for chronic pain, then when the effects wear off, what do? You increase the dose, right? And in some respects, that is faulty. Not in some respects, in many respects, that's faulty. And so at Yale, for example, and other medical schools, there are teams who are now training medical students on safe prescribing. And I'm part of that team at Yale, and we recommend to students not to prescribe opioids as a frontline treatment for chronic pain, right? It should come much, much further down the list. What should you start with? Probably something like interdisciplinary chronic pain. And there are different buckets that come in this. One is exercise, so get people moving. And this would involve things like physical therapy would fall into this, getting people walking. Another is medication. As we went over, it probably would involve things like NSAIDs, adjunct medications like antidepressants. Then there's a role for psychotherapy. Probably the most evidence-based are things like motivation interviewing, cognitive behavioral therapy, and acceptance and commitment therapy are probably the three that have the greatest research support. And then there's also a role for stress reduction. So stress reduction would include things like yoga, meditation, relaxation training. So these are the buckets that you probably should be looking for or at if you're interested in managing these patients, right? From a psychological perspective, we're looking at things like cognitions, emotions, behavior, and what people are attending to. And part of the role of CBT is to shift, for example, person's focus on their pain to something else, right? So the previous speaker had, this pretty nifty experiment where he had to stand up, focus on what was going on in our bodies. One of the things that people who've got chronic pain often do is pay exquisite attention to their pain and not attend to what else is going on, right? So part then of the task of when you're managing people with co-occurring opioid use disorder and chronic pain is to help them shift their attention away from their pain to something else, right? One of the ways that you do that is that you don't focus on the pain, right? So that if a patient is coming in to see me, for example, who's shuffling, and is exhibiting what's often called pain behaviors, I will not go, oh, you poor thing, right? I will ignore the shuffling and focus instead on functioning, right? Or if a person tells me I'm in pain, I typically don't ask them on a scale of 0 to 10, how much pain are you in, right? Because that's focusing their attention on their pain. Instead, what I will do is ask them how they're functioning. How are you coping with the pain, right? In some respects, you know, the way we come at pain in this country is quite different than the way we used to come at pain, right? I would imagine if you were to talk to your grandparents and ask them about pain, they would say something like pain is part of the human condition, right? And that it doesn't make sense maybe to eliminate pain, that part of being human is to cope with pain, right? In the era of opioid prescribing, that went out the window. And notions like the pain relief is a fundamental human right took place in this country, right? I would suggest that that comes with a lot of, that's fraught with danger, right? The part of our lives involves suffering, they involve pain, and that one of the ways I would approach the addiction and pain is to normalize it, right? And to go, well, yes, it makes sense that you're in pain. We're all in pain. How are you going to cope with it, right? And how are you going to cope with it in a way that doesn't involve taking short-acting opioids? Then there's also a social part of pain that often gets overlooked, right? And the pain can impact family. So if somebody's got low back pain, right? How long does a spouse or a family member remain empathic? Probably a week or so, right? After then a week, many people start saying things like, well, why does that person have pain, right? In the majority of cases of people who've got chronic pain, there's no objective CAT scan, PET scan, fMRI to back it up, right? That's the majority of people who've got chronic pain in this country, right? There's no objective evidence for it, right? Which puts them in an awkward position, and also the provider in an awkward position, right? That you're relying on then self-report, right? So part then of probably the treatment with this is also looking at what kind of messages are people getting from their loved ones, right? And what impact is it having on their family and on their loved ones? And work, you know, there are, if you look at disability claims in this country, chronic pain has steadily over the years increased in the proportion of disability payments. And this is a tricky kind of area, in part because if you look at the social factors that contribute to chronic pain, it tends to be people who are more disadvantaged, who are more at risk of having chronic pain. So people who are poorer, right, are more at risk of having chronic pain. And in some ways, the way I would view chronic pain is a marker for distress, right? That there's lots of things going on in the person's life that is probably not going well. And that, but if you look at the studies, for example, that treat people who've got chronic pain, they typically exclude people who are on disability, right? In part because there's an idea that they may not be motivated, right, to get well. And there's also increasing number of studies suggesting that once people go onto disability with back pain, they don't come off it, right? Okay, so we've already gone over some of this, that chronic pain is last 3 months or more. That's when the healing would have expected to have occurred. More and more, it's probably being viewed as a disease entity in its own right, and it interferes with the brain, especially even with the prefrontal cortex, right? And for somebody, for example, who has pain, it's often even hard to focus on what's going on around them, right? And part of that seems to be involved in the impact that chronic pain has on the brain. It isn't just that they're being awkward or being willful, but that it actually does impact having chronic pain, prefrontal cortical functioning. So 10% of the general population are thought to have chronic pain. If you were to go into primary care settings, it's 20%. The CDC estimates that 25 million Americans have chronic pain. And low back pain, which is the most common type of chronic pain, is one of the leading sources or causes of the disease burden in the United States and internationally. Okay. If you look, though, then at patients who've got opioid use disorder and who are involved in treatment for their opioid use disorder, either on methadone or buprenorphine, you can see that the rates of chronic pain are much higher, right? So they're much higher than the general population. In methadone, it's estimated between 37% to 60%. On buprenorphine, at least 36%, and some more recent studies suggest even higher. So where is then the pain located among patients who are in treatment for opioid use disorder? And this is an early study that my colleagues and I did, where we looked at patients who were coming on for treatment with buprenorphine for opioid use disorder, for different clinical trials involving buprenorphine. And we found that approximately 36% of the sample had chronic pain. And then we asked them just different questions about their pain, right? And you can see that the most frequently occurring site for chronic pain is back pain. And generally it's musculoskeletal pain. So legs, shoulders, less frequently are things like GI pain, pelvic-related pain, hands, arm, or face. And this in some ways mirrors what you see in a general population, right? That most people who are experiencing chronic pain, it's musculoskeletal pain. Where did the pain come from? So, for many patients, they reported that the pain came from an accident, right? And if somebody's got chronic pain and opioid use disorder, in some cases, the chronic pain comes first, right? Person gets prescribed an opioid, maybe then becomes addicted to opioids. The flip side is also true, that there are people who've got opioid use disorder who, when they're procuring drugs, when they're euphoric or high, are more at risk of getting into an accident. So sometimes the pain precedes opioid use disorder. In other cases, it's the reverse. You can see for some people, they don't know where the pain came from. And in some respects, then that adds to the burden of explaining to themselves and other people, what does this mean that I've got pain? Right? If you think about the book of Job, right, in the Old Testament or the Hebrew Bible, and Satan says to God, "You're pretty proud of Job. You say he's a decent, upstanding citizen, right? He's got lots of camels, he's got great family. He's an upstanding guy. It's no wonder that he follows you, because you've given him things. Put me in charge, and let's test Job." Right? What tests did Satan come up with? He started off by doing things like taking away his resources, his camels, his wealth. What did people around him start doing? They started wondering, what's going on with Job? Right? Why is he being punished? Right? Then there's a series of different tests involving family members dying off, right? And it ends up with what's the ultimate test, pain. That he gets these boils that are very painful. All the way along, people around him are going, why? Why is this happening to him? And at some level, Job was probably wondering the same thing, right? But the final test was pain. Even then, when Job withstood all these tests and professed faith, right? When he asked God, why? Why, God, did you do this? Why did you inflict pain on me? What was God's response? Who are you to question me? Who are you to question the maker of the universe? Right? I often think about that whole story when I'm treating people who've got chronic pain. That often they're not sure why they have chronic pain. They're questioning, why me? What does this mean that I've got this pain that doesn't go away? People around me are questioning, how truthful? There's no test to back this up. What's wrong with you? Are you being punished? And many people disown them, right? There are many people who've got chronic pain whose spouses end up divorcing them, separating from them, right? So this is often a condition that, even though I'm describing this as a chronic relapsing condition, it's often something that impacts multiple areas of the person's life, right? And not to be surprised if you have somebody with chronic pain who doesn't know where the pain came from, that doesn't mean that the pain isn't legitimate pain, right? And that the best estimate or measure we have of pain is still self-report. It does put the person though in this conundrum of explaining to himself or herself, what does it mean I've got chronic pain, explaining it to providers and explaining it to loved ones and friends, right? An interesting book came out around 10 years ago by Melanie Thernstrom, who wrote a book called The Pain Chronicles. And she was a writer for the New York Times. And she had chronic pain, and she went around to all these pain clinics and spoke to people in the waiting room of pain clinics. And one of the key themes that she discovered was that she came across patients who their loved ones didn't believe them, right? And viewed them with high suspicion that they had chronic pain, and also they suspected that their providers didn't believe them, and that their providers didn't like them, right? Which I suggest is something that you keep in mind as you're dealing with these patients, that they're often exquisitely sensitive to rejection and to how you're treating them, and if you believe them. And chances are they've come across a number of providers who don't. Okay, one of the questions that clinicians often have, among these patients, how do they manage their pain? And in many cases, what makes these difficult to treat patients in some ways is that they often turn to substances to manage their pain. So then one of the key strategies in managing these patients is to break the link between I'm in pain, I use a substance to manage my pain, right? So what are they using? Things from non-medical use of prescription opioids to benzodiazepines to alcohol. What's particularly concerning about the use of alcohol and benzodiazepines is that if you look at opioid overdose deaths, it's usually not just the opioids that are implicated. It's often people who've got benzodiazepines on board as well, or who've taken alcohol, right? That these add to the CNS or central nervous system depressant effects of opioids. Then one question to figure out is, well, what do people try on their own? Given that there are no evidence-based treatments for chronic pain and opioid use disorder together, what do people do? And what these people had done were things like taking over-the-counter pain medication, they'd taken and prescribed, or they had been prescribed and taken rather, opioid medications, they'd taken non-opioid medications, and benzodiazepines. And these were things that they had been prescribed and taken them as prescribed. There's a whole area of medicine called complementary alternative medicine, right? And then there's a branch of the NIH that deals with this type of medicine. One of the most frequent reasons why people take complementary alternative medicine is what? Pain. Pain relief, right? So one thing then to keep in mind is, what are your patients currently doing? And if you're not in the habit of asking them, I suggest that you do. So in this sample, you can see they had tried things like acupuncture, herbal medicine. Herbal medicine might be a concern if they're on medications in terms of side effects. In terms of mind-body interventions, a large number had tried prayer. And this is something that's often overlooked, I think, with our patients. And one of the things I generally do with patients is, if they mention prayer, is to ask them to give me an example, right? So that, for example, there's probably a difference between somebody who's saying to themselves, I'm being punished, God is punishing me, versus, for example, I grew up in Ireland. And when I grew up there, it was very conservative and very Roman Catholic. And my mom would say things like, offer it up for the poor souls in purgatory, right, if you were in pain. That, right, that there's meaning to this, or it could be not to dwell on the fact that you've got pain. They also tried things like counseling and meditation. Smaller numbers had tried things like yoga and hypnosis, even though these are also evidence-based treatments for chronic pain. And the majority had tried active, manipulative, and body-based methods like stretching or physical exercise, which is good because these are evidence-based treatments for pain management. Some had tried passive modalities like massage therapy, heat and cold therapy, and more than half had gone to a chiropractor. And there's still a lot of debate in the field about how evidence-based is chiropractic interventions. There's a back and forth in the field, but there are studies that suggest that it can be helpful. Okay, any questions so far on what we've gone over? Right? So far we've seen that there's a high co-prevalence of chronic pain and opiate use disorder. These patients who have the disorder use substances to manage their pain. They also use a variety of non-traditional interventions, and that it's probably worth your while checking with these patients what they're currently doing. Then if people are inactive, you might want to look at getting them active. If they're not taking medications, you might want to think about things like antidepressants, right? Or SNRIs or SSRIs. You might also want to think about things like relaxation therapy or stress reduction, and then things like CBT or motivational interviewing or acceptance and commitment therapy are the 3 evidence-based psychosocial treatments for folks who've got chronic pain. I'm now going to go over with you, these are results or baseline results from different clinical trials that we've done on people who've got opioid use disorder and chronic pain. And we had psychiatrists and psychologists interview these patients to try and figure out what were their psychiatric needs, right? And we used structured clinical interviews for DSM-4-TR, called a SCID, and then a diagnostic interview for personality disorders as well. And you can see with these patients who are coming on to treatment that approximately half of them had a mood disorder. And for those people who had a mood disorder, it wasn't going into remission. So one of the challenges that these patients seem to face is that, for example, there's some proportion of patients when they get depressed, their depression alleviates. With these patients, that did not seem to be the case. that once they made a lifetime diagnosis for mood disorder, they still met it, right? So there's something about these patients when they have depression that is not going into remission. You can see the most frequently occurring were major depressive disorder, recurrent or single, and then some proportion or smaller percentage had dysthymia or low-grade continuous negative affect, and then also manic depression or bipolar disorder. Again, you can see that approximately half of these patients had anxiety disorders, right? And that once they had a lifetime anxiety disorder, again, it wasn't going into remission, right? The most frequently occurring anxiety disorders were PTSD, panic disorder, and general anxiety disorder. And then minorities of folks had social phobia, specific phobia, or OCD. So, even based on those two slides, probably what you will often see in clinical practice is something like patients coming into you who are addicted to opioids, who've got chronic pain, who've got also depression and anxiety. And part of the question becomes, what do you address first? Right? From the evidence that we have so far, even though that patients might come through this at the lens of reduce my pain, then my mood will improve, and my anxiety will improve, that's not necessarily the case. That these are all two-way streets. So that if you can address the anxiety through either medications or psychosocial treatment, chances are the pain will improve, or if you can address the mood, right, either through medications or through psychosocial strategies, chances are they're going to be in a better position to manage their anxiety, right? And part of what makes these patients difficult to treat and why so many providers don't like treating them is that they have great clinical need, right? And not to underestimate that when you're dealing or treating these patients. What's interesting is that they also have non-opioid substance use disorders, but that the lifetime rates are quite different than the current rates. So in many cases, these additional non-opioid substance use disorders have gone into remission. But you can see the most frequently occurring current non-opioid substance use disorders were cocaine and cannabis. Right? And especially with cannabis, this becomes more complicated as different states are allowing medical use of marijuana and also recreational use, right? And most of the patients that I treat, I would say probably 90% or more use cannabis, right? In part to manage their pain and probably also in part to manage their sleep, that they say that they sleep better with cannabis on board. What also makes these patients maybe difficult to treat is the presence of personality disorders. These patients are also at high risk of having a personality disorder. Right? And the most frequently occurring in this study were, for cluster A, were paranoid, for cluster B were antisocial, and for cluster C were avoidant. Right? So that many providers, when they're treating these patients, have what's, in traditional psychoanalysis would be called countertransference, right? That they often dislike these patients and find them difficult to treat. And one of the common experiences, for example, of providers who deal with these patients is a sense of being shut down, right? That they get into this trap of, have you tried this? Have you tried that? And the patient goes, yes, I have. You don't know what you're talking about, right? So part of the strategies then involved in treating these patients is not to get into that dynamic. And part of that is probably fueled by the presence of that they're in distress, they have lots of anxiety, lots of depression, they're turning to substances to manage their pain, and that they're also prone to having personality disorders. What was interesting is that in the month prior to coming into treatment, that you can see that very few of them had been treated for these psychiatric disorders, right? So they were going untreated. Okay, I'm just going to draw your attention here to the right-hand column. This is a logistic regression model, and part of what it's doing is trying to predict. So one question is, how come? Why do so many people on methadone and buprenorphine have chronic pain, right? And I draw your attention to the right-hand column to the p-values. What this is saying here is that among these patients who were on methadone who had pain, that the drivers of pain were, first of all, if they were unemployed, they were more likely to have pain. If you then control for that, the people who had chronic pain versus acute pain were more likely to experience more pain. Then somatization, which overlaps with interception, right, that the previous speaker spoke about. This idea that when I experience stress, that I feel it in my body, right? That comes out as a predictor. But even when you control for that, one of the key predictors of people having pain is this notion of catastrophizing, right? So, if I were to have you all put your hands in a bucket of ice water, right, and have you report out loud what you're experiencing, chances are you would find a range of responses in terms of what you're experiencing. And there have been different studies done in college students who are healthy, who've got no psychiatric disorders, no pain history. You get them to put their hands in a bucket of ice water. What you see is a range from some students saying, this is interesting. This is an interesting sensation. I wonder how long I can keep my hand in this. I'm now noticing that there's a tingling sensation in my hand. It's moving up my arm, right? To the other extreme, and this follows kind of a bell-shaped curve or normal distribution. People on the other end are saying things out loud like, this is awful. This is the worst thing that's happened to me today. I don't understand why you're doing this to me, right? Why am I being punished, right? That ties into this notion of catastrophizing. It's the idea that people who have pain are focusing on their pain. By focusing on it, by paying attention to it, their pain experience is accentuating. They're feeling hopeless, helpless, and when they project themselves into the future, they assume that it's going to get worse, right? So for example, one of the first people I treated who had chronic pain and opioid use disorder was a Latino gentleman who said to me, well, I asked him how his day went yesterday, right? Describe your day to me. And he said, well, I woke up in the morning, it was raining outside. I felt a twinge in my back. I said to myself, my day is shot, right? I know that when it rains, I'm more likely to experience pain. I'm not going to go to work, right? Called out from work, then stayed in bed, focused on his pain, became depressed, then got up around 1 o'clock, went out and used as a way of coping with his distress, right? That would be an example of catastrophizing, right? So part then of when you're dealing with these patients is to listen out to how they're describing their pain and to look for what might be called thinking errors, right, from a cognitive behavioral therapy point of view, right? And a classic thinking error is catastrophizing. Another study that we did highlighted that people who have chronic pain are pessimistic, and that even one episode of chronic pain in a person's life can make them more prone to pessimism rather than optimism, right? So to keep that in mind when you're dealing with these patients, that they tend to be pessimistic. So part of it, when I'm working with patients, what I try and do is increase their optimism, right? And actually directly address their optimism. How do you do that? You look at how they describe the universe and how they describe their pain, right? And you highlight when they're being pessimistic, and then you try and help them to be optimistic. A key deficit as well of these patients is that they don't exercise. So among methadone-maintained patients, for example, in this study, we found that 20% of those who had chronic pain were exercising. Those without chronic pain on methadone, 30% were exercising regularly, right? So, and in some respects, this is not unique to methadone patients or buprenorphine patients. There are many people in the general population, right, who don't exercise, right? And it's becoming increasingly evident from the studies as people age. If you want to age successfully, what do? You stay physically active. It's probably the key recommendation, right, for all of us as we get older. Then one question is, are patients who are in methadone treatment or buprenorphine treatment who've got chronic pain, are they interested in receiving treatment for both? And we found that yes, they are, right? That they want on-site treatment. Okay, what's it like working with these patients, right? This is one of the studies that we've done in this area where we looked at drug counselors or addiction counselors who were working in methadone programs, right? So the standard of care in a methadone program is something like daily dosing of methadone plus availability of on-site counseling. Addiction counselors typically are not trained in pain management, right? So what's it like then being a counselor in a methadone clinic where you've been trained to work with people with opioid use disorder and a high proportion of your patients have chronic pain, right? So I'm going to quickly walk you down through these. And this is based on qualitative interviews, key things were they lacked expertise in pain and opioid use disorder. They had difficulty managing the patient's needs, which isn't surprising given the high rates of anxiety, depression, right, and non-opioid substance use disorders and personality disorders. They had concerns about medication regimens. Many of these patients are engaged in what's called rational polypharmacy, so they're often 5, 6, 7, 8 medications, right? And they had concerns about how do you keep track of side effects, and often by different providers, right, which makes it even more concerning. Then reliance and self-report. Could they trust these patients and what they were saying about their pain? Things that help them were empathy. So trying to understand what's it like being this patient. Attending to small changes, not expecting large changes, but even very small changes, and highlighting that for the patient. And then self-reflection. Some providers experience being sucked in to their patients' lives, right, who are miserable. And the part of what seemed to help some of these providers were having a good observing ego, being able to pull back, say, this is not me, this is my patient who's experiencing this, how can I help them understand what they're experiencing? Then patient factors were, well, from their interactions with patients, what were their patients thinking? One of the things then is medical providers, that medical providers don't care about them, right? Then if you look at logistic factors, pain management referrals, where do we send these patients? The majority of pain clinics offer opioids. These patients who've got an opioid use disorder are often ruled out from going to regular pain clinics. So what do we do with them? In case you're thinking, that's addiction counselors. This would not apply to physicians. That's incorrect. We've found that when we do similar studies with physicians, that a very similar set of concerns come up about treating these patients. That they're unsure how to assess pain. They weren't trained on chronic pain management. They're typically trained in acute pain management as physicians. They have difficulty managing coexisting disorders. They don't like having to rely on patient self-report. And where do we send these patients? I don't like treating them. I want to send them to people who specialize in this. And there are not many people who specialize in co-occurring chronic pain and opioid use disorder. So this says here, next step. He's complaining of chest pain, shortness of breath, cramps, and dizziness. Do you sell earplugs? Right? So at this stage then, right, we've got that there are many people who've got both of these conditions. They're in a lot of distress. They use substances to manage their pain. There's a lack of treatment facilities who will help them. Methadone clinics, buprenorphine clinics, and naltrexone clinics are set up to manage opioid use disorder, not pain. Pain clinics are typically set up to manage pain and not substance use disorders, right? So then the question is, what do we do, right? So what we decided to do was to try and do something ourselves and to build up a treatment model that would address the needs of people who've got opioid use disorder and chronic pain as they come on to opioid agonist treatment with either buprenorphine or methadone. So, as I said at the beginning of this talk, there's evidence that opioid medications are very good for managing cancer pain and end-of-life pain. I would say a caveat even about the cancer pain. I collaborate with some, like with the cancer clinic at Yale, and what they're becoming increasingly concerned about is that more and more, as treatments get better for cancer, more and more people are surviving cancer. They've been given high doses of opioids to manage their cancer pain. Once the cancer is going into remission, what do we do about the opioids, right? And that the focus of the oncologist is we should make sure that people are not in pain and that they survive the cancer, right? But even in this area of cancer pain, I would imagine in years to come, we will see more debate about what is the role of opioids in cancer pain management, right? There's also general consensus that for acute pain, this is good, right? Or it's okay. But the CDC guidelines that came out a couple of years ago now recommend that if you're going to manage acute pain with opioids, you prescribe 2 or 3 days worth. 10 years ago, it would have been 30 days worth, or up to 90 days worth, right? Those days are hopefully past us, right? So the new guidelines are very restrictive use of opioids for acute pain and get the person back in and try and switch them to something else, right? When I started off doing this work, and I would go to pain conferences, people would say to me, what are you talking about? Just give them more opioids, right? What you need to do is get people on methadone or buprenorphine and then give short-acting opioids. That's the way that you'll address this, right? And that people who've got pain are immune to addiction, right? So the people that you're telling me about who've got chronic pain and opioid use disorder, they had the opioid use disorder first, then they developed the chronic pain. It wasn't the other way around, right? That pendulum has swung, right? And those myths are thankfully no longer as prevalent. But we had concerns about, well, for people who are addicted, is this wise to give them short-acting opioids for their pain? And we thought not. And that we thought that there was evidence that opioids lose efficacy over time, and that's borne out to be true, that they do. And there used to be a lot of emphasis at NIH on tamper-resistant opioid medications, but still, whatever they came out with, patients were able to bypass the mechanisms by and large. And there's not as much emphasis nowadays on these tamper-resistant. Okay, so the approach that we take is that we provide opioid agonist treatment specifically to manage opioid use disorder. Right? So the purpose of then of the prescribing is not for the chronic pain, it's for opioid use disorder. Right? And as I said at the beginning of this talk, It's to decrease withdrawal symptoms, prevent the person from getting a high if they use, and to block cravings. Most people who take methadone or buprenorphine report that for a couple of hours after taking it, that their pain gets a bit better. So that would be one window of opportunity then when you're thinking about getting people to be more active, to get them to do it after they've been prescribed the medication. The first psychosocial treatment that we have been working with is cognitive behavioral therapy, because this was shown to be effective for substance use disorders in general and for chronic pain, but trials had not examined CBT for people who had both chronic pain and opioid use disorder. So this is the overall model of what we're trying to do with CBT for pain and opioid use disorder, right? We've got people who've got pain have certain thoughts like, I can't tolerate the pain, I can't move without my pain getting worse, right? So this is one area then that you're going to address these thoughts. Feelings like anxious and depressed. This is another area for intervention to try and reduce down the anxiety and depression. And then behavior, people become inactive. Also, as people become inactive, their social world tends to shrink, right? The same way with Job, who people left him and his social world constricted. It's often the same with patients who've got chronic pain. So one of the strategies is to try and increase their pleasure quotient and to get them interacting with other people, right? Because often the thought is something like, I need the pain to go away before I can interact with other people, right? So you want to try and reverse that. If you were doing CBT on people with chronic pain alone, you would be dealing with the bottom half of this diagram. For the people who are addicted to opioids, there's often a connection then between this and up here. So part then of what this approach tries to do is to break the link between I'm in pain, therefore I use. And it's a learned automatic behavior. Because even though there's often immediate pain relief and the person feels better in the short term, in the long term it's risky, and one of the things it can do is actually lower pain thresholds, right? So one of them of, the dilemmas that people face as such when they're on opioids is that opioids actually lower pain thresholds, right? And there's a classic series of experiments that have been done, with putting your hand in this bucket of ice water, that when you compare people who have ever been on methadone, who have, for opioid use disorder, people who have been prescribed opioids for pain, and then people in a general population who don't have pain or any addiction of it, or any history of addiction, what you find is that the people on methadone, buprenorphine, who have ever been on opioids have lower pain thresholds, right? So that they're more prone to experiencing pain, right? Which in some ways then probably speaks to that we should not be relying on opioids as the primary treatment for pain, right? Okay, so I'm now going to go over with you skills that are covered in CBT. And I'm going to come back to this one in a bit, because this is one of the take-home points of today's presentation, is probably to understand the difference between acute and chronic pain. And the strategies that are used for acute pain don't work for the strategies for chronic pain, right? And that many patients and members of the general public, when you look at their theory of pain, it's more appropriate for acute pain, but not for chronic pain, right? And that lands people in difficulty in terms of then how they approach management of chronic pain. And I'm going to come back to this in a bit. So many patients are inactive. This can contribute to deconditioning and pain worsening. It promotes passivity and avoidance. So one of the things you want to do, get people moving. Don't have to send them to the gym, get them walking, right? And usually what I will do with my patients, especially the people who are sedentary, the people who've got walkers, is I will walk with them. And rather than saying, well, how motivated are you to walk? What would make you more motivated to walk, right? And coming in and talking about motivation, actually do it. Get up and walk with them, right? Is usually what I do. And then I ask them afterwards, how did you manage to do it? What was it like walking? Better to achieve it and discuss it versus plan it, not achieve it, and discuss why you didn't reach the goal, right? So for people who are sedentary, I'll even just have them, I'll walk with them even like 100 feet when they tell me they can't walk, right? Just to get them in the habit of moving. Because one of the things you're going to find as you get people moving is that they're going to tell you about their thoughts, right? And if they say things like, I'm broken, exercise is bad for me, right? These are thoughts that can be addressed, right? Many patients have difficulty tolerating distress. This can contribute to, the previous speaker spoke about the negative side of, or dark side of addiction, managing distress. That's true with these patients as well, and it can lead to inappropriate opioid medication use. So things like deep breathing, progressive muscular relaxation, and visualization. So even if you only have 20 minutes with a patient, I would suggest you consider doing one of these things for the first 5 minutes. And if they're coming in saying, I'm in pain, I'm overwhelmed, that you not address their pain, you not address their being overwhelmed, that you simply offer a safe space and go through something like this. Have them relax, have them take deep breaths, right? And then rather than talking about what's going wrong, ask them about, what was that like, right? How did you manage to do that? When you came in at the beginning, you said your life was falling apart. Now you've managed to focus on breathing, you've managed to relax. How did you do it? How can you do this again? Right? Then coping with pain and cravings. So we would expect with substance use disorders and chronic pain that people are occasionally going to become symptomatic. One of the ways that people become symptomatic with pain is that they have pain flare-ups. Right? They experience a spike in pain. For opioid use disorder, they can experience cravings out of the blue. Right? So one of the things that you want to do with these patients is, in some ways, not to have them catastrophize, right? And to view this as being symptomatic. And just because they have this symptom doesn't mean that they're going to relapse, right? So there are many patients, for example, who've been abstinent for drugs for years, who will come across a cue that was associated with drug use, who will have a craving, and then who will go, wow, there's something terribly wrong, right? In fact, there's not something terribly wrong. These are learned behaviors, right? And as the previous speaker spoke about, there are areas of the brain that explain how these are ingrained learned behaviors. So one of the things that you want them to do is to work their way through the pain flare-up or the craving. How do you do that? Things like distraction, positive self-talk, review the negative consequences of using, and urge surfing, which can be difficult for patients to do, but it's this idea of, I'm going to sit back and observe what I'm experiencing, right? And that I'm going to have faith that there's going to be an increase, but then it's going to start decreasing eventually. And that I just, as my pain is getting worse, or as my cravings are getting worse, if I don't use and let it peak and come down, I'm going to unlearn this link between having pain and using opioids. Does that make sense? Mm-hmm. Right? And that can be difficult to do. So usually I start with the other strategies first. Right? Then we already went over this idea of catastrophizing, and it promotes anxiety, depression, and lower quality of life. It can contribute to inactivity. You know, from a CBT perspective, our thoughts, feelings, and behaviors are important. And part then of dealing with catastrophizing is replacing these thoughts with more realistic thoughts, having them come up with positive coping statements like, well, I got through this before, I can do it again, right? If you take, for example, a person who gets lost in a city and who starts getting anxious in a place that they don't know, maybe they're driving through a neighborhood, they're unsure where they are, they feel themselves getting stressed. The people who say to themselves things like, I can do this, right? I got lost, I've gotten lost before, I can get out of this, I'm going to be okay, are much better problem solvers than the people who go, this is catastrophic. I'm in a neighborhood, I don't know where I am, I could get mugged, I could get carjacked, right? What's that doing? It's fueling anxiety and decreasing the person's ability to problem solve. So what you want them to do then is in some ways self-soothe, right? Many patients focus on what's going wrong, right? And that can lead to helplessness or depression. So part then of training people to be optimistic is to get them to become more aware of things that are going well in their lives, even very small things, right? And to savor them, right? And the smaller the better. Even things like somebody said hello to me this morning. The weather was nice when I got up, right? Very, very small things that you have them recognize that's a positive thing and savor it. Because people who've got opioid use disorder and chronic pain are very quick to dismiss positive events. And what are they more likely to focus on? Negative things. So you want to get them to reverse that, right? And when things go wrong, what they often do is the classic pessimistic trick of when things go wrong, I blame myself, there's something wrong with me, right? You want them to get to unlearn that. That when things go wrong, you want them to figure out what's their role in it and what can they learn from it, rather than saying, I'm flawed or there's something wrong with me, right? And this is why bad things happen to me, right? You want to get them to unlearn that. So as you can see, in some ways, this is an optimistic kind of treatment, right? And that it's not just focusing on, oh, you poor thing, you're in pain. Let's just do this, that, or the other, right? It's really getting to know the person and helping them improve their functioning and not just their pain. Many people view this use of opioids as beyond their control. Of course I'm going to use. You don't know what it's like being in pain. What else am I going to do, right? You want then to break the link between being in pain and using. So this is, classic exercise in CBT or cognitive behavior therapy, where you look at what came before the behavior. So what sets me up to use? What was I thinking? What was I feeling? What did I do then? Then looking also at the consequences. What were the positive and negative? The rationale for doing this is that you try and slow down the person so it no longer becomes automatic. They become more aware of their link between, I'm in pain, I'm going to use a substance, and you have them pull back and go, I'm in pain. In the past, I've used substances. What are the pros and cons of doing that? Right? And many patients are not assertive. Right? So what we go over with them are things like passive communication, aggressive communication, passive-aggressive, and assertive. And one of the areas that this can come in useful is for not just refusing drugs, for example, when they're offered drugs, but also for how to talk to physicians, nurses, or providers, right? How to become assertive in terms of explaining to a provider, this is what's going on with me, and this is what I need, and this is what I want you to do, right? And not to assume, because many patients assume that the providers don't like them or are out to get them, and they can quickly switch from being assertive to being passive-aggressive or aggressive, right? But when that happens, usually it does not get their needs met. Okay, so we've got then different CBT protocols where we offer this in 10 or 12 sessions. We've got a beginning, middle, and end. The beginning is just setting up the session, asking them how their week went, how they're coping with their pain, how their substance use is going. In the middle, we go over one of the skills that we went over, with the deficits and how we try and address them. And then we assign assessments, homework assignments rather, to practice these skills. Right? And we've done a couple of randomized clinical trials, one in the methadone clinic, one in buprenorphine clinic, and this approach seems to work. Right? That what happens is that people's substance use goes down when they break this link. In the methadone trial, their pain decreased, but more specifically what increased was their ability to cope with the pain. Right? I'm going to skip forward here to this. Yeah, I'm just actually going to, rather than going through the slides, just walk you through the story of what we did next, because I think we're running out of time. Right? Any questions on this so far? Okay, so one question that then becomes, well, so you've got these protocols that in ideal treatment settings might work, right? One of the reasons why there's such a gap between the research world and the clinical world is that research is typically conducted in idealized settings, right? So that, and also that you've got, in like these clinical trials, you've got people who are motivated to come in for the treatment, right? That's why they're there, right? So they've already bought into what you're doing, right? Which is not the case in routine clinical practice. They're also getting paid for their time. Right? They're getting paid to show up, to do the assessments. The assessments are typically on the same day that they're getting the intervention, right? In the real world, we don't pay patients to turn up, right? So question then, and sometimes researchers, I think, are overly harsh in terms of wondering why is it that evidence-based treatments don't get implemented in routine clinical practice, right? I think in part because the original trials are often not done in routine clinical practice, right? And that, so we've got this protocol for 10 or 12 sessions. Who's going to pay for it? What clinics are going to send people away to get trained on this, to do it? And also, what's the, even if you do, the rates of turnover in clinic settings are high, right? So many people who you train will leave, right? So as a result, many clinical settings don't implement evidence-based psychosocial treatments. And to me, that's no great shock, right? Then the question becomes, can you dismantle this approach into routine clinical settings? So I'm affiliated with a not-for-profit organization in New Haven where we have 4,800 methadone patients. So we're one of the largest providers of methadone in southern New England. In that clinic, as in many methadone clinics, individual treatment is not the norm. It's group treatment, right? And they have a model whereby we give patients a choice of 10 or 12 groups a day. They can decide which groups they're going to attend. And if you come to one group, you don't have to come back to it. You can go to a different group next time around, right? And the minimum dose of groups is 1 a month, right? Because that then is consistent with federal guidelines around clinical contacts. So what we've done then with this approach is to dismantle, right, this treatment so that we have walking groups. We have people drop in to a group where we take them out and walk. We have people come in where, and I'm going to go over a slide in a minute, where we go over the differences between acute and chronic pain and then recommend that they walk. We've done groups like singing, right, where we have people come in and sing with the idea of increasing their pleasure quotient. And then we track before and after these groups how much pain they're in, their anxiety and their depression. And what we found is that with these different types of groups, that typically a person's either interference in functioning because of pain goes down, or their anxiety or depression, right? So the take-home message from that is something like, don't be overwhelmed by the idea that people have pain and that you need to directly address the pain. There are multiple ways to address pain. If you come up with strategies for helping relaxation, anxiety, depression, distracting people away from their pain, you're probably helping them. Okay, then I'm going to go over then, lastly, the difference between acute and chronic pain. And if there's one take-home message from today, I would suggest this is it. That most people who've got chronic pain have a model of pain that's more consistent with acute pain. What's acute pain? Acute pain is new pain. It's typically related to tissue damage. That you can say to a patient who's got acute pain, so a person breaks her ankle, goes to a primary care doc or to a nurse. The nurse or the primary care doc can say, look, your pain will likely go away. If you put too much pressure on your ankle, your pain will increase. It's a reliable signal that potential damage might be happening. Pay attention to your pain, right? And it's a reliable signal that something bad might happen. With chronic pain, pain has lasted 3 months or more. The healing is complete, more or less by 3 months in most cases. The reality is that the pain intensity the person is experiencing may never go away. That's the reality. And the pain is no longer a reliable signal. So if you can imagine then you've got chronic pain and you're telling yourself, I'm not going to walk because I'm in pain. I'm in too much pain. This is a reliable signal that something's going wrong. That's actually incorrect, right? That part of the dilemma that people with chronic pain face is that the pain signal is no longer accurate, right? Which is a really difficult situation to be in. Because most of us, when we have pain, we've learned that, right, we need to pay attention to the pain and it serves a function. In the case of chronic pain, that typically is not the case, right? And that's one reason why you don't focus on the person's pain and have them direct their lives around the pain, because it's no longer a reliable signal of tissue damage. For people who've got acute pain, typically the treatments are things like medication, rest, and surgery. Even depending on the acute pain, nowadays it's typically you get people to move more quickly as well than in the past. The model is something like the provider is the expert, and the goal is complete pain relief. For people who've got chronic pain, that's not true. That acute pain, strategies for managing acute pain often make chronic pain worse, not better. Even though the person might feel hopeless, helpless, want somebody to take their pain away, the evidence-based model is self-management. Similar to hypertension, similar to diabetes, that the people who do better are those people who take more control of their pain. So part of what you're doing then, if you're a nurse, if you're a physician, if you're a counselor, your role is to promote self-management of pain. And then the treatment goal here is not eliminating the pain, it's coping with the pain or managing it.
Well, let's give Dr. Berry a hand.
Okay, thank you.
Great job.